going to talk about something completely different. DRUJ instability, when to open, how to stabilize. And Dr. Harvard said it's controversial, and we'll kind of discuss that towards the end of my talk. Because I do have a disclosure, and it is at the end of my talk. Okay? So if you want to learn DRUJ instability, you actually have to learn stability, which actually is very detailed and is kind of complex. I'm going to try to summarize it in a couple of slides. So you have to look at the bony congruence of the DRUJ, the sigmoid notch. There are static and dynamic stabilizers, and static being arguably more important than the dynamic stabilizers. So in terms of the bony anatomy, it contributes about 20% to stability of the DRUJ. Most of the bony architecture is this flat segment, about 42%. And so inherently, it could be a very unstable joint if you don't have those static and dynamic stabilizers. The dynamic stabilizers include the pronary quadratus and the ECU, which I'm going to kind of skip over because I think what's more important are the primary stabilizers, specifically the TFCC, and there's also a component of the DRUJ capsule, but it's mostly the TFCC. And if you do lose the primary stabilizers, you need a secondary stabilizers. And this is where sometimes we overlook the DIOM, which is the distal interosseous membrane. We all have a DIOM, but then some of us also have a bigger band called the DOB, which is the distal oblique bundle. This is more the new kid in the block. And so in terms of the TFCC components, it's actually quite complex if you look at it in this schematic. But then I wanted to just highlight that the deep fibers of the dorsal and palmar radioulnar ligaments, that is the main stabilizers for DRUJ stability. If you get an MRI, here you can see the deep, you can actually see in this cut the deep fibers of the TFCC, and there's also a superficial component that attaches to the tip of the styloid. And so when we look at ulnar styloid fractures, we actually, if you see a small tip fractures, we're not really that concerned about DRUJ instability unless they have avulsion that you didn't see. But when you see a basal fracture, more towards the base of the ulnar styloid, that's when you start thinking that the deep fibers might be affected. One thing about this MRI that also shows here, like, we're taught that if you see a signal on a T2 equals T2 H2O, and then it's like an injury, right? If anything lights up. But in the TFCC, what divides the superficial and deep fibers is this ligament called ligamentum subcreantum, which is like a fibrocartilaginous structure that divides the two lamina. So this is actually not pathologic. You have to be careful. Like I mentioned, we all have a DIOM, and where do you find it? If you actually peel back, if you elevate the pronary quadratus, underneath you'll see the DIOM. 60% of us will have this like thin layer, but then 40% of us will have this thicker DOB, distal oblique bundle. And this is also controversial. There's a lot of studies, a lot from Japan actually say that if you have a DOB that's a stronger secondary stabilizer, right, it kind of makes sense. So you have a TFCC tear, but then you could still be stable because you have a strong DOB. But then there's a paper last year from Dr. Orbay that says that actually it may not be true. So the jury, I think, is still not out on this DOB. Why does it matter? Why does the DOB matter? And I wanted to sort of shift this. I know this is about the DRUJ, but I want to shift this talk about the coronal shift, which is the radial translation of the distal radius. Sometimes we fix the distal radius, there's like a millimeter or two offset, and we think it's fine. The problem is if you have a TFCC tear and you have this coronal shift, then you could have a loose DOB, which would result in an unstable DRUJ. So if you fix the DRUJ and you have a little bit of coronal shift, if you fix the distal radius, you have a little bit of coronal shift, and you test the DRUJ and it's unstable, this first step is not to go after the TFCC, it's actually to go after the radius. Make sure you correct this coronal shift to tension the DOB, and you may not have to go after the TFCC. Likewise, you could also see this in a distal radius fracture where you have shortening and you have loosening of the DOB and the TFCC tear. And you could, like this video I showed, the DRUJ can be quite unstable if you have that. This is actually a malunion case, but then it kind of illustrates how unstable a DRUJ can be if you have shortening of the radius. And acutely, what you would do is you try to restore radial length to tension the DOB. In a more chronic case, like the case I showed, I actually prefer to do ulnar shortening osteotomy, actually, to tension the DOB. And this is the patient with extraarticular distal radius fracture that was shortened. And after ulnar shortening osteotomy, the DRJ is stable. And I did have this mark just in case I have to go after a TFCC. If the patient had maybe like a DIOM that was flimsy and I didn't get the stability I wanted, then I could go after a TFCC, but I didn't have to in this case. All right, so let's go through 3 scenarios and a couple of cases where I consider opening the DRJ. Number 1, I think for me, this is not very controversial when you have a displaced sigmoid notch. So this is a 67-year-old female ground level fall. So if you look at this fracture, you're like, it doesn't look that bad, I'm just gonna cast it, right? But then a couple of things that I wanna point out is if you look at this lateral, there's actually in this segment here, there's sort of like a more radiolucency. It tells me there's like a gap in the sigmoid notch. And just looking at this X-ray, this oblique X-ray, there is this dorsal ulnar corner that Dr. Schroeder mentioned, and probably some depression here. But then you could confirm this with the CT scan, which shows here that there's some depression of the lunate facet, and then you see, of the radiocarpal joint. And here's the dorsal ulnar corner that's sort of unstable. And why is it unstable? So if you look at the DRJ congruency, this gap and this gap, there's actually some widening, which tells me that the DRJ is unstable. And so that was my indication for surgery. This is also controversial. I actually ran it through a couple of my colleagues. They're like, why are you fixing it? And I said, because I actually believe that, I could spend like an hour talking about geriatric fracture, distal radius fractures, but I think if you have an unstable joint, it doesn't matter if you're 65, 67, 70, you still have an unstable joint, so you need to fix it. So intra-op, pre-op, she actually did have an unstable DRJ once I took her off her splint, and she had crepitus with a shuck. And so I did a dorsal approach, and then I actually elevated the fragment, and then I fixed the DRJ, and then she actually did pretty well. Dr. Alnaga, he's one of the spine trauma surgeons. When he was a resident, he wrote this paper, the dorsal tangential view. And so if you look at this view, you can see that the DRJ has been restored, okay? It's a useful view to look at the DRJ. So 3 months post-op, full pronation supination. She's still pretty stiff, but 3 months, this is expected. She's pretty happy. Second scenario is when you have open DRJ dislocation. So I work at a level 1 trauma hospital. We see some high energy injuries. And so this is a 29-year-old female. She had an MBC. This is open Galeazzi, also had a open calcaneus fracture. And so just to go back here, look at the extent of this injury. This is not just a distal radius fracture. Look where the ulna is basically dislocated, right? And so the problem with that, the problem with that is we know there's going to be a lot of soft tissue stripping. So the first thing I did is I IND'd the open fracture. So this is not iatrogenic. I actually just opened it, extended it, and you have to go after the TFCC. So look at this. There's no capsule, right? It's a avulsed, and then the TFCC is completely torn. This is like a naked distal ulna. And also sometimes they'll dislocate and they'll reduce, and what gets entrapped can be like a tendon. And this is the EDM tendon that was entrapped. This is the problem if you just fix the radius and you pin it, then you may have EDM trapped in the tendon. You might have a TFCC that's completely avulsed and distal radius, ulna that also doesn't have any TFCC attachments. So for me, in open injuries, high energy open injuries, I'm gonna go explore the DRJ. Okay, and this is the sequence. One thing I did use for this case, I just wanted to point out, is that the patient had avulsed TFCC, and for this particular case, I like using Keith needles, and I used a bone tunnel, so I had a very good access to the TFCC, so I could look at it. So I did like a horizontal mattress with 2 fiber wire, and then I used 2 Keith needles, and I basically go through the fovea, and then I thread my my fiber wire, and I just pull it, and then it just kind of probably saves you about 10 minutes, and it's a good technique to get bone tunnels. Also, fix the capsule. Okay. Now, I do use suture anchors. This is a 34-year-old male MVC. Also, look at the displacement of the DREJ. I don't have any intraoperative pictures, but then this is also like a naked distal ulna. Everything was completely avulsed. I was looking at the TFCC, so I put an anchor and I fixed it, and then I put a dorsal spanning plate for the distal radius. Okay? Now, the third clinical scenario, some people ask me this, when do you decide to just go after the ulnar styloid fragment? And this is when, first of all, you have to make sure that the distal radius is fixed correctly. So I discussed this concept of the coronal shift, and also restore the radial height. So once I do that, I know that the distal radius is good, then I still have instability, and I have a big ulnar styloid fragment. That's when I go after the ulnar styloid. And this is, I think, the part that's a little bit controversial, and which I will discuss. So 36-year-old male, motorcycle accident. Once again, here, look at the displacement of the radius. This is not just the distal radius fracture. The thing that pops out for me is this, that the ulnar styloid, which sits here, is here. And why is it sitting there? It's because something is pulling it, which is the TFCC. So I know there's a TFCC injury. This is the distal radius fracture, comminuted, fixed it with a plate and K-wire, and then tested the DRUJ, and it's unstable. So now I don't see any coronal shift. I think I got radial length, right? And so I have this big piece, which makes it relatively easy to fix. We all do tension bands. Olecranon is like the biggest tension band, right? So, or patella. So the way I do a tension band, I use a static tension band. There's two ways to approach ulnar styloid. I like to use this hockey stick type of incision, but you can also go straight longitudinal. You have to be careful with the dorsal cutaneous branch of the ulnar nerves. There's usually about 2 branches. But once you get that out of the way, you're pretty safe. And I use a K-wire, and then I use a static tension band. I use Ethibond. I use 3-0 Ethibond. Why not use something bigger? It's kind of subcutaneous, and it could bother them. So I use 3-0 Ethibonds. I use 3 because my residents always break the first one, and they have 2 as a backup. Okay? And so this is the x-rays at 6 weeks. I take out the K-wires. Now, this one is a lady, same concept, shifted, the ulnar styloid is over here. She had carpal tunnel syndrome. So post-reduction, she has coronal shift, big styloid, carpal tunnel. So this, for me, was an indication for surgery. I discussed non-operative treatment, but then she wanted to proceed with surgery. Immediate post-op, this looks pretty good. I mean, restored the radius. I did a tension band I taught you. I left this wire percutaneous, right? And the reason I wanted to, this is kind of like a repeat of the last story, but then this is why this one changed my practice. I'll tell you why. So don't worry about this little suture. I just made a mistake. I tried to get cute and put 2 suture down my styloid. It didn't work out, so I just did a tension band. So she did well, right? She had no signs of infection, and then she came back at 3 months, and then she had full range of motion, no pain, no signs of infection. And I looked at X-ray, and look at that. There's an erosion, right? And so this case is really sad for me because she actually had osteo, right? She did IND and hardware removal, but then what was also sad was that I lost her because this is March 2020. This is COVID when everything shut down in the cities, and so they couldn't come back to the hospital and blah, blah, blah. And so, but then this actually changed my practice because now what I do is I bury my tension bands. I actually cut it under the skin, and I put it under the skin. And since pretty much every K-wire that you use, even for the fingers, I talked to them about cutting under the skin, I've had 0 infection, right? It makes sense. It's under the skin. Even though it's a second procedure sometimes, I just think it's better than getting an infection, okay? And then in 3 months, she did pretty well. Finally, this is, I do use also a push lock, and there's a specific indication. This is a 40-year-old male who had this pretty bad distal radius fracture. I fixed the radius. If you look at the radial column, there's actually no bone whatsoever. But here, I actually used the push lock instead of a tension band. And the reason I didn't use a tension band is because the tip of the styloid is really, really tiny. I can't really fix that. But I do also have this shoulder, right? And I'm going to reference this. I have no financial relationship with Arthrex, but then it's actually a good video by Dr. Stephen Shin online. And here, what you do is you make a longitudinal incision, you open up the extensor retinaculum, and then you do a capsulotomy. And this is the styloid, and this is the TFCC. You do a horizontal mattress, and then you actually straddle the shoulder of the ulnar styloid to put in your push lock. So in my case, I had this ulnar styloid shoulder, and so I could use a push lock for this case. So this is the disclosure. I told you about how to that we should open the TFCC, right? I actually do open my TFCC. I don't pin it anymore, right? And then this is a study written by this is a meta-analysis, 8 studies by one of our residents. Actually, she was a medical student. And I told her she ruined my talk because I spent 10 minutes talking to you about opening the TFCC, and then her study says that actually you may actually do worse if you open it. But this is the caveat. I think for the sigmoid notch, I think you have to open it. I think you have to get the bone correct. For open dislocations, you're staring at it, you might as well fix it, right? I think it is a little bit controversial. Like, what do you do if you have a distal radius fracture that is fixed well and the DRJ is unstable? What should you do? I think if you know how to fix it, you can go after it, but then I think it's still okay to pin it. The problem is you can have, there's a lot of pin side complications with pinning the DRJ, which I did not get into, but that's also changed my practice. Thank you.